right, welcome everyone to our latest Queen Elizabeth Scholarship webinar from the McMaster Health Forum here at McMaster University in Hamilton, Ontario. This is actually our last webinar for the term in fall of 2017, but we will definitely have more in 2018. Here's a quick agenda of what we will be covering today. I'm going to tell you a little bit about the McMaster Health Forum, a little bit about our version of the Queen Elizabeth Scholarship Program, and then I'll just turn it over to our guest speaker who is a Queen Elizabeth scholar, Eilish, who went to Australia, and she'll tell you about the work that she did while she was there. So the McMaster Health Forum is the leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, prepare action-oriented leaders, and act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The version of the Queen Elizabeth Scholarship Program that's offered through the McMaster Health Forum is called Strengthening Health Systems. Our scholars contribute to strengthening health systems and become part of our large and growing network of health system leaders. We've had 2 cohorts of scholars so far. This on the screen now is our first cohort. They primarily went away or visited us in 2016. And our much larger second cohort, which is on the screen now, primarily went away or visited us in 2017. Eilish comes from this group, and she's the lone outgoing scholar from this group, meaning that she is a graduate student who went and did scholarly work at one of our Commonwealth partners. And speaking of which, here's Eilish. So Eilish is our presenter today. She is currently a Master of Science in Global Health Program student here at McMaster University. Her primary research interests lie in the study of marginalized communities and the ways in which the many dimensions of an individual's identity interact with health systems. She used her time abroad to conduct research for her thesis on health provision in the prison system. Eilish hopes to apply her experiences in research to gain unique insight into an often invisible health system and looks forward to extending this knowledge to the Canadian prison system. So that's a little summary. She will now go into far more detail than that. Please let me introduce you to Eilish.
All right, thank you very much for the intro, James, and thank you everyone for coming. As James mentioned, my name is Eilish, and I am currently a Master's of Science in Global Health candidate. I'm in the midst of sort of writing my thesis, which, as James mentioned, focuses on prison health prevention, or prison health provision in Canada. So just a quick agenda for today. I'm going to touch on the main research that I did while I was in Sydney, which actually focused on hepatitis C research. And I carried out this research at the Centre for Social Research in Health, which I'll refer to as CSRH from now on to save the syllables. I'll then go on to touch on health in the incarcerated population, which is an area of study that I touched on in Sydney and which I'm continuing now. And then I'll briefly touch on some important lessons learned from my time abroad. So just to get going, I had a wonderful time living in Australia. On the left here is a photo of Gordons Bay, which is located from the walk from Coogee Beach to Bondi Beach, which I live just 5 minutes from. And it's important to keep in mind, looking at this photo here, that that's actually Australian winter. So things are looking slightly different for us now. And the photo on the right is one of my classmates that I encountered on my commute to school each day. It was a stressful few weeks until I asked someone if these birds were vicious. It turns out they're not. Very tame trash birds. So as I mentioned, I worked at the Centre for Social Research in Health under the supervision of Professor Carla Treloar, who's pictured here. The CSRH has the mission to undertake and promote exemplary social and behavioral science research in health that informs and strengthens knowledge, policy, and practice. And I can confidently say after 3 months working with Professor Treloar that I upheld this mission. So the primary research that I focused on in Australia examined the factors affecting the elimination of hepatitis C, or HCV. So Hep C is a global health concern as 71.1 million people live with this disease worldwide. It's an infectious disease that primarily affects the liver, and it's bloodborne, so it's transmitted when the blood of a person who's infected comes into contact with the bloodstream of another person. So in light of this, the most common route of transmission is needle sharing. Chronic HCV infection negatively impacts a person's quality of life, and it can lead to cirrhosis and cancer of the liver. Given the route of transmission, the burden of HCV falls disproportionately on people who inject drugs. And you'll see this referred to as PWID in the slides from now on. The World Health Organization aims to eliminate HCV by 2030. And this is a goal that's been strengthened by the recent development of highly effective direct-acting antiviral treatments. This just came about in the past couple of years. So in contrast to the past interferon-based treatments, which often had side effects such as nausea, depression, and fever, DAAs offer a more tolerable alternative. However, despite this development in treatment, the number of people that live with hepatitis C globally continues to rise. So studying HCV in Australia was a uniquely interesting experience. In 2015, the country's government invested $1 billion in the elimination effort for the next 5 years. And in doing so, they ensured universal access for all Australians that live with this disease. So key to this universal access was the government's ability to negotiate lower drug prices among the sector. In contrast, prices for treatment in Canada range anywhere from $50,000 to $80,000 per treatment round, which means that not all patients are eligible to receive this treatment. Although changes to this are happening provincially, and we'll have more access in the future, which is great news. So the Kirby Institute, a partner institute also at the University of New South Wales, which is where the centre I was working at is based, has reported that Australia is on track to eliminate Hep C by 2026. So given that the disproportionate burden of Hep C lies with people who inject drugs, this population was a major focus for my research. My primary research interests, as James mentioned, lie in the study of marginalized communities and the ways in which the many dimensions of an individual's identity interact with health systems. So the work that I was able to do was very challenging and fulfilling. The exploration of factors affecting the elimination of Hep C is what constituted the bulk of my work at CSRH. So people who inject drugs must be of primary focus in the elimination effort, given that they experience the highest rates of hepatitis C. However, treatment provision for people who inject drugs remains inadequate, despite this population's willingness to engage with treatment. So while drug use doesn't actually affect the efficacy of a given treatment, provider concerns such as poor adherence and risk of reinfection often present barriers en route to treatment. So in what was truly an international experience, Carla and I teamed up with Dr. Kyle Dyer and Rob Calder from King's College in London, England, to examine hepatitis C knowledge and training among workers in the alcohol and other drug sector. And you'll see alcohol and other drug referred to as AOD on the slides. So evidence suggests that AOD services are an effective tool that link people who inject drugs with care, and that AOD workers are crucial in these efforts. Many health and AOD sector professionals report having limited HCV training experience, but workers in this sector are absolutely necessary to reduce gaps in the HCV care cascade, which you can see pictured here. The HCV care cascade basically describes how a patient travels through the journey to treatment, from being diagnosed with the infection all the way through to follow-up care. So given that 85% of HCV prevalence in England can be attributed to the injection of drugs, the training of these workers is a crucial pursuit. In conducting this research, I learned a great deal about the multifactorial nature of HCV elimination. So once there's a curative treatment, people tend to assume that the path to elimination is just a simple means of administering this drug to the affected population. However, the elimination of any disease, not just hepatitis C, is far more complicated. I was fortunate to work with some of Australia's leading experts on hepatitis C, and through both my own research and a number of different seminars and workshops that I attended, I developed my knowledge on the topic. There are a number of different models of care that are effective along the HCV care cascade. And this diagram is an oversimplification, but I think it touches on a number of important points of care. So of particular interest are the non-traditional care pathways, those that lie outside the primary and specialist care services. So things like community-based care, peer-based models of care, and alcohol and other drug services have been found to be highly effective in providing care, treatment, and support at different points along the HCV care cascade. As I mentioned before, my primary focus lay with AOD services and the crucial importance of training AOD workers and linking people who inject drugs to care. One of the most important factors to consider when considering the elimination of hepatitis C, are the populations that are uniquely affected by this disease. So for instance, as you can see, indigenous persons, incarcerated persons, and as I've mentioned, people who inject drugs face greater barriers to care. And a lot of this has to do with the systemic barriers such as stigma, which I'll touch on in a moment. It's also important to remember that these population groups aren't necessarily mutually exclusive. So people who fall into one or more of these categories can face heightened cultural insensitivity, stigma, and discrimination on their pathway to care. There are also a number of different enablers and obstacles that can either facilitate or impede a person's access to diagnosis, treatment, and support. It's important to note here that while something can act as an enabler in one context, it can act as an inhibitor in another, something to keep in mind. So for instance, issues of stigma, discrimination, and housing can prevent a person from the stability and the trust that are required to navigate the professional-patient relationship and to complete their treatment course. Policy can act as an obstacle, but it can also act as an enabler. So to give you an example, the South Australian Prisoner Blood-Borne Virus Prevention Action Plan of 2017 to 2020 is an Australian policy that aims to address the heightened levels of infectious disease among the incarcerated population. They aim to both reduce transmission and the clinical and social impact of a diagnosis for a person who lives in custody. So as I've mentioned, workforce training was of primary interest to my research in Sydney, given our study of the important role that AOD professionals play in linking clients to care. So if professionals are reporting limited HCV training and experience, as the literature shows they often are, these patients are going to face greater barriers. However, the reverse of this is also true, and this needs to be explored. A robust and equitable health system that promotes positive interactions at different points of care, as well as equitable access to treatment, is a fundamental necessity in the quest to eliminate any disease, not just hepatitis C. So to examine workforce training needs, our team based in Australia and in England examined the results of a survey on hepatitis C knowledge and experience that was administered to 5 major alcohol and other drug treatment providers in Great Britain. There are a number of important results in this work, a few of which I'll outline here. And this paper has been submitted for publication, so just cross your fingers that you see these one day. We found that hepatitis C knowledge was actually lower among participants who carried a caseload. So this is a concerning finding given that workers who carry a caseload are the workers that have direct points of contact with clients who are in need. These workers were also significantly less likely to report awareness of a curative HCV treatment. Lower knowledge was seen in younger participants and those who have worked for a shorter period of time. So this isn't necessarily surprising. Someone who's just coming into the field to work won't have the same level of knowledge and experience as someone who's worked for 20 or 30 years. But given the fast evolution of Hep C treatment, this finding indicates that it's important to keep updated and ongoing training in the workforce. Finally, perhaps our most surprising finding is that 40% of respondents incorrectly reported that there is no cure for hepatitis C. So it's evident here that there's a significant knowledge gap among a highly influential workforce, and this needs to be addressed. So this research experience was a really wonderful learning opportunity, and I had the chance to work in a very international group to explore a timely and relevant topic. As a result of this research, I learned a great deal about the many factors that contribute to the elimination of a disease like hepatitis C. So simply having a curative treatment, while it's a very exciting scientific advance, isn't sufficient. Workforce training has to be provided to ensure that healthcare providers are able to help patients successfully navigate this care cascade. Training in this area should also address the associations between hepatitis C, injection drug use, and stigma, as the literature shows that real or perceived discrimination from health professionals can discourage patients from seeking care. This brings me to the next point of my presentation, where I get the chance to discuss with you the work that I'm doing now and the lessons I learned at the Center for Social Research and Health that are guiding this work. So as I've mentioned, the bulk of my research in Sydney focused on people who inject drugs, as this population is uniquely affected by hepatitis C. There's an overrepresentation of people who inject drugs in prisons globally, making the incarcerated population particularly at risk of infection and transmission. Compounding this heightened risk are the added barriers to care that exist for persons in custody whose access to primary and specialist services are already limited. The CSRH is currently implementing a study called Stop C in conjunction with the Kirby Institute. This program aims to assess the feasibility of hepatitis C treatment as prevention in Australia's prisons, and it's being conducted at 4 New South Wales correctional institutes at the moment. It aims to monitor HCV incidence and prevalence as persons in custody come into facilities and to administer treatment as prevention. The cost effectiveness and budget impact of this treatment as prevention program are going to be evaluated with the intention to scale up this treatment countrywide. So I'm in the midst of writing my master's thesis, lucky me, under the supervision of the wonderful Dr. Fiona Kuyunjin. And I'm focusing on health among Canada's incarcerated population. So this actually started as a project that examined Hep C rates in Canada's federal prisons, partly inspired by the Stop C project at CSRH. So while an estimated 30% of federal inmates in Canada's federal prisons are infected with hepatitis C, the treatment of this disease has actually fallen within prisons in recent years. And this is despite the exciting scientific advances that I mentioned previously. So this project blossomed into a more inclusive examination of health in Canadian federal prisons. It's a timely topic, as the Canadian government just put out a call to the public to hear what we think about justice reform in the country. So unlike the general population, whose health is governed by the Canada Health Act, the health of Canada's federal prisoners is actually governed by the Corrections and Conditional Release Act. My thesis is a policy analysis of this act, and it looks to deconstruct how health is differently represented as a topic in this piece of legislation versus how it's represented for the general population. The incarcerated population represents some of society's most marginalized persons. 25% of people in prison are Indigenous, which is a gross overrepresentation. Most persons report drug use in the past. Many persons report histories of trauma and abuse, and mental illness is endemic. Given the fact that prisons represent a high concentration of people in society with the greatest health needs, it's possible that these places could serve as places of treatment and of healing. So I'm hoping that my work on this topic can contribute positively to healthcare reform within our federal prisons. So my time at CSRH showed me that conducting research in prisons is actually quite a tricky feat. So engaging with the Stop C project, I had insight into what conducting research in prisons actually looks like. Unfortunately, I didn't actually get to go into prisons, but one day. There are a number of administrative hurdles that come up when you're trying to run a project within a prison. So for instance, there are often a number of different ethics committees that you have to go to, which can take months to years. A project's goals may compete with the goals and interests of correctional services themselves, of justice health groups, and of other interest groups. In speaking with members of the Stop C team, I learned that correctional services can be difficult to work with, as their main priority is often just housing inmates. It's not necessarily providing them with health. There's, of course, the issue of which prisons to initiate a project within, as every prison houses a uniquely different population with slightly different needs and different cultures. So as I'd mentioned, the incarcerated population has unique health needs, which demand action. However, space within prisons is limited, and interventions aren't easy to coordinate. There are only certain times that you're able to see your patients. In speaking with one member on the Stop C project, she cited a time that they got all ready to go into work, they headed in, and within minutes there was a lockdown in the prison, and that was their workday over with. So beyond this unpredictability, inmates themselves only have a certain amount of free time in a day, and they may not want to spend it in your clinic. So in light of that, engaging with the inmates themselves as individuals and spreading interest among groups is key to the success of a project such as Stop C. Overall, people in custody do want to get better. They do want to receive treatment, and word spreads fast about this possibility. Sometimes officers may not be so keen to promote education and well-being. I was told that finding a dedicated officer is key, and this is usually a person who is moving persons through the prison. Overall, it's clear that staff have to be on board to make an intervention work. So researchers need to be flexible and they need to be creative. Prisoners in Australia move on average 9 times a year, so continuity of care is very difficult. While in medium and minimum security prisons there's more access to contraband, drugs, and clean needles, needle security is strict across the prison system. However, research has shown that harm reduction tools, such as safe needle exchanges, don't actually increase risks within prisons. They promote well-being and reduce transmission of infection. So it's possible that harm reduction should be something that we're pursuing in prisons globally. So this takes me on now to some important lessons learned from my time in Australia. Number one, explore your own backyard. My parents will tell you that I did plenty of this. Pictured on the right here, or on the left, I suppose, again from the walk from Coogee Beach to Bondi Beach is that famous swimming pool. And on the right is a stunning sunset over the Sydney Harbour Bridge. Lesson number two is make your research matter. So as a researcher, I was truly fortunate to work at CSRH under the supervision of Carla Treloar. Carla involved me not only in discussion and writing, but in a range of different community engagements that demonstrated the true power of research. So for instance, I attended a number of different seminars and conferences, visited Sydney's supervised injection site, and attended Overdose Prevention Awareness Day. I had the chance to talk to people who actually had lived experience with the things I was studying. Through my experience at CSRH, I reshaped my perception of the importance of research. And as a student, this perception is constantly growing and constantly changing, but I thought it was important to share some insights. As our man Oscar Wilde famously said, the truth is rarely pure and never simple. So in an effort to get slightly closer to the truth through research, I've created a little list of steps to consider when entering the field. I learned that it was crucially important to listen, not only to the voice of the majority, but especially to the people living on the margins who are most affected by factors such as stigma and systemic barriers. I learned to observe before you make assumptions. Deep-rooted and invisible assumptions can undermine progress in a number of ways, and it's important to recognize these at every stage of research. Considering issues at hand, asking questions, and admitting your own shortcomings as a researcher can only strengthen the end result of your hard work. The people with the answers aren't always the ones who are sitting behind desks writing letters. It's important to hear from people who will be affected by the policy or the plan that you're contributing to. Conducting research that keeps all of these factors in mind is key, but it can't stop there. CSRH taught me the importance of celebrating successes, focusing on points of weakness, and unrelentingly advocating for work that you believe in. So just to put it in a bit of context, I was in Australia at a very interesting time. As the same-sex marriage plebiscite, the public vote, was underway. So since my departure, same-sex marriage has been passed, and I've missed a lot of really great parties. The legislation is, of course, something to be celebrated widely. However, the harms that have resulted from the public debate on the legitimacy of LGBTQ relationships can't be ignored. In 2016, before this decision to hold a public vote, CSRH, in conjunction with ACON, which was formerly the AIDS Council of New South Wales, released this report on the impacts of marriage equality and marriage denial on the health of lesbian, gay, and bisexual people. This report pointed to the positive health impacts that marriage equality can, of course, have on LGBT people, and it actually advised against a potentially harmful plebiscite, arguing instead that this debate should happen solely within the walls of Australian Parliament. So if everyone had made the same effort to listen, observe, and consider, perhaps a great deal of harm could have been avoided. I was very fortunate to witness and be a part of this type of research and advocacy during my time at CSRH, and I look forward to carrying these skills forward. And the final lesson, of course, is to remember that snow is never far away. It doesn't matter where in the world you are, it will find you. Thank you very much.
Thank you very much, Eilish, for your presentation. Very interesting, very informative. Sounds like you had a wonderful time. You learned a lot. So we'll open it up to questions. For those of you who are joining us online, I'm going to ask you please type your questions in the chat box, and I will read them out for the recording. For those of you who have joined us in the room, if you have a question, feel free to put your hand up, and I'll come to you and have you ask your question. So I'll start. Lots of questions that I could ask. I kept going through a list of questions as I was listening to your presentation. So I'll start with a systems level question because we are the health forum after all. So you did a nice job of talking about the Canadian health system and how it relates to the prison system. Those multiple layers are always difficult from a policy perspective. How is Australian system set up to care for their incarcerated individuals? Do they have a similar type of extra tier of policy, or are they covered under the main Australian legislations?
That's a really great question, James. Thanks for asking it. As far as I know, the Canadian system is unique in that certain inmates are considered federal. If you're going to be incarcerated for 2 years or more, you become the federal government's responsibility. And if you are going to be in prison for a shorter amount of time, you're the responsibility of the provincial government. So in Australia, there isn't this same division between federal and provincial that we see here. So in that sense, perhaps there's a little bit more onus on the individual providers of healthcare because the health policies that apply to the general population typically apply as well to the incarcerated population. But that being said, there are still the same health inequities existing, even despite this difference in ownership. So I think that just because there are these policies that apply, it doesn't necessarily mean that they're translating into equitable levels of care. So yeah, that's a great question. Thank you.
Thank you. And again, I'll ask if anybody in the room has questions. Feel free to put your hand up. Yes, we have a question. So you can ask it from there, and I'll repeat it for the sake of the recording. How about that? So the question that's been asked in the room, it has to do with whether or not there is a corresponding relationship between HIV infection rates and Hep C infection rates, and if there is, I'll let you kind of finish the end of that.
Yeah. No, that's a great question because given the route of transmission, you'd expect that there would be a high concordance, and there definitely is. The center that I was working at has in the past done a great deal of work on HIV/AIDS. And the change sort of in emphasis from HIV to Hep C sort of follows the level of interest among funders. There's always a great level of interest in HIV research, and it affects the same sort of population. But Hep C hasn't been in the public eye for as long. It doesn't have the same sort of traction in the news as HIV does. So yeah, I think it's both diseases and both infections are prevalent among this population, but they garner very different levels of interest from health groups. So that is sort of the reason for the emphasis of my work on Hep C.
Again, anybody online who has any questions, feel free to type it in the chat box. Someone else in the room has a question. Okay, so the question in the room has to do with the universal availability of Hep C drugs. In Australia, they are available, and wondering whether or not they're available here in Canada. And
yeah, so I think that the difficulty in answering that question comes from how different levels of care are between provinces. So I believe in BC, there's more movement right now to make Hep C available regardless of your level of disease progression. Whereas in other provinces, there hasn't been the same sort of momentum. And it's difficult to find that, like I included the range that, treatment can cost anywhere between $50,000 to $80,000. It's difficult to find those statistics because a lot of the negotiation for lower drug prices is a private government affair. So yeah, I think BC and Ontario and I think one eastern province are sort of leading the way, and I think early 2018 we're going to be seeing some progress in making these drugs more universally accessible. But there hasn't been this sort of unified push Canada-wide to make these drugs universally accessible to everyone, which I think is what we should be focusing on because it saw a lot of success in Australia, the federal government taking responsibility for something like that.
so again, another call out for questions. If anybody in the room has a question. Oh, we have one more. The room is hopping today. So budget allocation for healthcare in the prison system compared to the regular average population, as it were.
Are you speaking about Canada specifically? Yeah. So the budget allocation is significantly less overall. And the issue is that correctional services is given a certain budget per year, and they're allowed to decide how they would like to spend that money. So I'm not going to say the statistic because I can't confidently say it, but it's a small percentage of their overall budget goes towards health. And it's the number one complaint coming from people in custody is the level of care that's provided. It's just simply not adequate.
Any other questions from anyone in the room? Anybody online? I might ask a question or two if we don't have any. Oh, we got another one from the room. Go ahead. How is the provincial prison systems treating the Hep C drugs as opposed to the federal inmates? And then the follow-up question was, so that's the question. So the difference between the provinces and the federal government.
Yeah, that's a great question. So provincial incarcerated care is a responsibility of the province itself. So those inmates are covered by the Canada Health Act. But interestingly, just to add to that, my supervisor, Dr. Kyunjin, is a physician in Barton Street Jail, and she has cited, you would think that people who are living in custody for shorter periods of time would be of greater focus for health provision, given that it's more of a public health issue if you're going to be going into and coming out of institutions as the population often is. But she has cited some difficulties in accessing care, like Hep C treatment. You're not eligible to start it when you're living in a provincial facility, which I didn't know, whereas in a federal institution you are. So maybe there's like a little bit of a double-edged sword in being in for a shorter period of time. Even though you are the responsibility of the province, there I think are some different loopholes that exist in not having to provide certain treatments while you're incarcerated. Yeah. Well, interestingly, so it's not like politicians are totally unaware. There's a case right now at the Supreme Court level of a past inmate, Stephen Simons is his name, who someone used one of his needles while he was in a federal institution, and when he went to use it, he was infected with hepatitis C. And that is the responsibility of the institution that essentially allowed that to happen. So I think in 2012 that was brought to the courts, and it's still sort of just sitting on a table somewhere. So I think that it's an exciting time because they did just put out this call for public opinion on how to reform this justice system. So I think people need to be taking more ownership for the health needs of not just the general population, but invisible populations as well, as we touched on.
Another call for questions. Anybody online, feel free to use the chat box. Anyone else in the room? I mean, there's a number of other questions that I would like to ask, but I will spare you. I'll ask you a travel question. So you stayed near Bondi Beach, which is internationally famous for one thing. So I'm curious, did you do any surfing?
Yes. Well, I actually stayed near Coogee Beach. The surf wasn't as good there, but I did manage to get out on the board once or twice. Yeah, I'm not very graceful on a surfboard, but it was good for photos, so it looks like I was. That's all that matters.
Perception is really the main thing. Yeah,
exactly.
Absolutely. Great. So, and last call for questions, if anybody has any? No? All right. So, thank you. I have one more slide to show you. This is just a quick links for you to take a quick look at. That first link that you see on the slide there links to our Queen Elizabeth Scholarship page here at the forum, gives you all the information you need to know about it. So if you're interested in our program, please visit that link. The second link is a link to all of our webinars. So all of our scholars do a webinar when they return from abroad. Eilish is the last one for this cycle, but we will have more coming in the spring. We have 4 students who are currently abroad right now. So they will do other webinars in early 2018, so please refer back to that link for a complete list of those webinars, past and present. And then the third link, all of our scholars also write a blog about their experiences, so please visit that third link to read the blog posts and read a little bit more in depth about some of the things that they experienced while they were abroad. And thank you very much, Eilish, for rounding us out for this cycle, taking the time to come in and do this presentation. And thank you, everyone, for joining us here today, and we look forward to seeing you again, hopefully.
Thank you.
Thank you.